Welcome back to Open Med School. Today I am going to discuss with you Internal Medicine Competency 1.21. So we'll start with a case scenario. It's a 25-year-old male admitted with a fever of 2 weeks, fatigue and weight loss. On examination there is a cardiac murmur. What is your diagnosis? Of course this patient has got a fever of 2 weeks. So can be all differential diagnosis for PUO should be kept in mind. So in this specific situation with a valvular lesion or a murmur, we have to consider whether it's a rheumatic fever. Can this be infective endocarditis? Tuberculosis should always be considered. And weight loss, fatiguability, consider possibility of malignancy. But the age is little odd for these things. So the important differential diagnosis in a PUO which you are likely to miss is infective endocarditis because often it is not in our differential list. Today's learning objectives are identify the clinical features of endocarditis, yes, infective endocarditis, differentiate acute versus subacute endocarditis, and how to interpret the cultures and echo. Let us look into the definition of endocarditis. Infection of the endocardial surface of the heart. As per Harrison, microbial infection of the endothelial surface of the heart. This includes the valves also. So when you say endocarditis, usually we are concerned with the lesions occurring on the valves. The core lesion of infected endocarditis is a formation of vegetation. What is a vegetation? Vegetation is a mixture of platelets, fibrin and bacteria. Brunwald says the cardinal lesion of endocarditis is the vegetation. So this usually occurs on the valves. Here you can see in the mitral valve the vegetations are there. This is one of the major criteria for making a diagnosis of infective endocarditis. Now we go into the classification. This infection can occur in native valve, that is normal valve, or it can occur in the prosthetic valve. So mainly infective endocarditis, depending upon the valvular structure, this can be native valve endocarditis, prosthetic valve endocarditis, or a patient with a structurally abnormal valve. Another classification is divided into acute infective endocarditis and subacute endocarditis. Prosthetic valve endocarditis usually divided into early prosthetic valve when the infection occurs the first 60 days. Acute infective endocarditis, as the term itself denotes, it is acute in onset. It is starts with a high fever, patient with toxic, and very important, it usually affects the normal valve. So acute infective endocarditis usually occurs in the normal valve, and the organism is Staph aureus. So remember these 2 points. Normal endocarditis can occur in the normal valves or in the, and the common organism is Staphylococcus aureus. Whereas subacute infective endocarditis, or previously called subacute bacterial endocarditis, it is insidious. The fever is usually low grade and commonly it occurs in abnormal valve, and the Streptococcus viridans is the commonest organism. The most common, around 30% cases, is the viridans streptococci. So now we think which valve is affected in IV drug usage, intravenous drug usage. This usually occurs in the normal valve, already we have mentioned. This is naturally the tricuspid valve because from the veins the blood is entering the right atrium, then it enters through the tricuspid valve into the right ventricle. So it usually affects the tricuspid valve. So this is going to be, so whenever you get a tricuspid valve endocarditis, think about IV drug use, and usually say acute endocarditis. What are the etiological factors? We have mentioned two important organisms. One is the staph aureus. Previously, Streptococcus viridans was the most common organism, but now the staph aureus is becoming more common. Then enterococci. These three organisms, around 80 to 90% of the endocarditis is by these three organisms. The HASEC organisms, Staphylococcus galolyticus, or sorry, not Staphylococcus, Streptococcus galolyticus or Streptococcus bovis, otherwise called, this is important because in patients with carcinoma colon, this is the most common organism. So somebody with a carcinoma colon and coming with endocarditis, think about Streptococcus bovis or Streptococcus galolyticus. What is the pathogenesis? There should be an endothelial injury. There is one thing, there is an endothelial injury. This may be due to the hemodynamic factors. There is already, the valve is abnormal, definitely there is already an injured area is there. Where the fibrin platelet clot occurs. Whenever there is a bacteria entering, the bacteria will get attached to it and it forms what is called the vegetations. There is a role of hemodynamics in the formation. So in a patient with aortic valve endocarditis, the vegetation is usually seen on the ventricular surface of the valve. So in the aortic valve, it is in the ventricular side of the aortic valve. Whereas in case of mitral regurgitation, it is usually seen on the atrial side of the mitral valve. Then we go into the clinical features and overview. Fever, murmur, embolic bar immune phenomena. This is the classical triad of findings we can get. Let us go into one by one. What is the most consistent sign of infective endocarditis? It is the fever, present in more than 90% of patients. So remember that 10% of patients with infective endocarditis can present without fever. They may be presenting with worsening heart failure, or they may present with a stroke. So that should be kept in mind. Then regarding the murmur, the appearance of a new murmur or a change in the quality of the murmur, both are important. Already patient has got a murmur, a change in the quality, or a new murmur, both are significant. The most common cause of death in infective endocarditis, what do you think? Most point is heart failure. So one of the important point to remember, there are certain stigmata of infective endocarditis. The stigmas or stigmata are due to either embolic phenomena, or it can be due to immune manifestations. This is a very important point in the general examination you have to look for. Let us look into Osler's notes. We are very familiar. Osler's notes are 3 P's. They are painful, pulp of finger, P size. So these are 3 P's regarding pain. So remember, it is painful, P sized, pulp of finger. So if you palpate, there will be tenderness. It is due to immune complex. So Osler is due to immune complex. Similar lesion on the hands, but they are painless. It is embolic. It is embolic. So Genevae is embolic. It is seen in the hands. Another is splinter hemorrhages. It is again microemboli. Again the rose spots, they are immune. So rose spots, Osler's nodes, and glomerulonephritis. Patients can develop hematuria, microscopic hematuria. This is glomerulonephritis. 3 important immune manifestations are, remember, Osler. So Osler, rose spot, and glomerulonephritis. Genevae lesion and splinter hemorrhages are microemboli. Osler I already mentioned, painful, pulp of finger. So this is, it may be on the, you just palpate. This is the Genevae lesion. Genevae lesions are painless as mentioned, it is due to septic emboli. This is a rose spot in the fundus. You can see a white area surrounded by the. Again, this is immune manifestation. Immune. Rose spots are retinal hemorrhages occurring. Rose spots are not specific for infective endocarditis. It can occur in other conditions. For example, it can get in leukemia, you may get. Then this is splinter hemorrhage. Splinter hemorrhages are longitudinal. So the most common cause is usually trauma. Following a trauma, you can get in collagen disease like systemic lupus erythematosus and in trichinosis you can get. But the clinically relevant, this finding is infective endocarditis. Embolic phenomena, we have already mentioned embolic phenomena. Genival lesion is embolic. Genival lesions. Then the splinter hemorrhage is embolic. Patient can develop a stroke due to embolism. You can get a renal infarction. So renal infarction is embolic, whereas the glomerulonephritis is immune manifestation. Now we go into the immune phenomena. We have already mentioned the glomerulonephritis, various vasculitis. In the vasculitis, remember the Osler and the rose spot. So you can remember there is in the O, the R is there. So Osler and rose spot and glomerulonephritis. These are the easy to remember. Osler, O, R, G. Then we think about the acute versus subacute. Already mentioned, acute is rapid, it's destructive lesions occurring. Subacute is slow and it is immune mediated. So immune mediated findings are, we have mentioned that they are seen in not in acute one. What are the immune manifestation? The glomerulonephritis, ocellates, and the rose spot. And the rose spot. These are immune manifestation and usually seen in subacute rather than in acute endocarditis. For the diagnosis, we use the Duke's criteria and the modified Duke criteria. There are two major criteria. We'll discuss this in a little more detail later. One is the typical blood culture positivity. Regarding the culture, during that phase, we'll discuss what is by typical and atypical blood culture and a characteristic echo positivity. These are the two major criteria. Presence of two major criteria is sufficient to make a diagnosis, diagnosis of infective endocarditis, clinical diagnosis. Pathological diagnosis by examining the valves or the materials and establishing the organism. Here is a clinical diagnosis, two major criteria. Or one major plus three minor. You can, or five minor criteria. Just now remember this point only. The details of the Duke's criteria will be discussed in another session. So what are the minor criteria? First and foremost is the fever. Second is risk factors for endocarditis. One is abnormal valve. Second example is the IDU, intravenous drug abuse or drug use, prosthetic valve, etc. Features of embolic phenomena, features of immune phenomena. So, and blood culture not consistent with a typical organism. So we have mentioned what is done by the typical. So atypical findings in the blood culture. Again, you take it as a, you can consider it as a. So these are the five criteria. So how will you make a diagnosis? Two major criteria, one major plus three minor criteria, or five minor criteria. You can make a clinical diagnosis. Then this is the diagnosis of endocarditis. You can use the tip. So here you can see the temperature more than, the minor criteria are temperature more than 38. Immunological phenomena, we have already mentioned oscillation nodes and rose spot. Microbiological evidence other than the typical. Embolic phenomena, and risk factors like palliation, congenital heart disease, IV drug use, etc. The two major criteria are B. Blood culture positivity, echocardiographic evidence of endocardial involvement. The blood culture should be taken minimum 3 blood cultures. 3 blood cultures at least 1 hour apart. Of which 2 should be positive. Then only you can take it as a tip. And you should find typical organisms that cause endocarditis. So 3 samples from different sites and should be taken, of course, before antibiotics. So if you don't take the culture before antibiotics, you may get what is called culture negative endocarditis. The common things are, one is the prior antibiotics, Coxiella burnetii, Bartonella species, and of course the HACCP organisms. Then echocardiography is the key investigation. The initial test is transthoracic echocardiography. In order to exclude transesophageal should be done, so usually you go for an initial test. Transesophageal echocardiography is the most sensitive, TEE 90%, more than 90%. The characteristic echo findings are presence of vegetations, valve dilation, valve perforation, valve abscess formation, presence of new regurgitation. What are the complications? I already told that the death is usually due to congestive heart failure. You can develop stroke due to systemic embolization, myocardic aneurysms, immune phenomena, glomerular nephritis, myocardic aneurysm already I mentioned. You can get abscess formation various places. Now we are going to the principles of therapy. Antibiotics should be given IV and long-term therapy, approximately 4 to 6 weeks of antibiotic therapy. So start with empirical therapy, and then depending upon the organism, you go for the change the antibiotics. The empirical therapy usually aim at covering staphylococcus and streptococcus. You can use ceftriaxone plus gentamicin or crystalline penicillin either as infusion or repeated doses. The details of therapy I will discuss in another session. And the duration of therapy is 4 to 6 weeks. Remember, it's a 4 to 6 weeks of IV antibiotics. And sometimes surgery is indicated when they are required. One, uncontrolled infection in the antibiotics in the patient is not responding. Recurrent embolization, large vegetation more than 10 millimeter can be taken. And in prosthetic valve endocarditis is a definite indication the patient, the valve has to be replaced. So in short, fever plus murmur plus emboli, transesophageal echography is the best. 3 cultures before antibiotics. Heart failure is an indication of surgery. Stay tuned for further videos. Thank you.